bit more about treatable traits. We've got some opportunity later today at 4:20 to do some voting and feedback some results from yesterday. So just to remind you, the treatable trait is clinically relevant, measurable and treatable, and it is talking about clinical characteristics, which we've heard a bit about, so I won't spend too much time on this, but in the ERS monograph, some of these clinical characteristics were described. We've heard about COPD, bronchiectasis, pulmonary hypertension, also lung cancer, TB relapse, and also respiratory infectious disease. So all of these are clinical characteristics that could potentially be traits. Post-TB mortality is really important, and that's one of the reasons for focusing on these. So that's an important hard clinical outcome that we've heard a little bit about, but we should think about traits that might affect mortality as an important clinical outcome. What is the cause of post-TB death? We looked at data from Australia, and this is 3 cohorts of over 7,000 people in each cohort, and linked to the national database. This is not yet published, it's in press, but basically the TB cohort significantly were more likely to die from respiratory infections, from respiratory specific cause of death, and interestingly lung cancer at 2 to 5 years post-TB diagnosis. This is an example of one of my patients recently that had a nodule that got bigger on TB treatment for MDR-TB, not smaller, and an FDG PET scan and subsequent biopsy proved it to be adenocarcinoma. Post-TB COPD, there's good evidence for systematic review that we did some time ago, looked at data from the Global Burden of Obstructive Lung Disease BOLD studies, and also 3 studies that looked at CT diagnosed bronchiectasis. And the overall odds ratio was just over 3 for the increased risk of COPD and bronchiectasis, both airway-centric diseases. In our study in Peru, we looked at drug susceptible and MDR-TB, and importantly compared that to healthy controls from the same population. And we did that DAG that Camilla was talking about with adjusting for air pollution, smoking, and also allergy and other important cofactors, and still found those significant associations in a young population. Pulmonary hypertension, there's the review that Brian mentioned yesterday, led by Jennifer, talking about post-TB pulmonary hypertension, 67% in a chronic respiratory failure group, and lower in hospitalised and non-hospitalised patients. Another important characteristic is non-tuberculous mycobacterium. So this is a study from South Korea looking at those patients with confirmed Mycobacterium pulmonary disease from NTM, Mycobacterium avium, and interestingly 42% of those nearly 1,000 adults had a history of previous tuberculosis, and I think this is what we see in clinical practice often. Post-TB phenotypes we've heard a little bit about. This is some data from Australia. This was the first published study that's been published about a month ago in BMC and Pulmonary Medicine, looking at a cohort of Australian patients. So certainly this idea that maybe there's very little post-tuberculosis lung disease in a high-income setting because we diagnosed TB earlier, but in fact in this population we found 75% with abnormal complex lung function of any type. We used plethysmography and DLCO, half had abnormal DLCO. We found more, interestingly, than has been presented elsewhere, 49% with an obstructive deficit. These were mainly people that were some years post-TB completion of treatment successfully. So that sort of changed from a mixed pattern or restrictive pattern to obstructive over time, I think has been described as well previously. We also looked at CT imaging findings and found 29% with bronchiectasis. We also found a lot with evidence of pulmonary fibrosis on imaging, and using a CT diagnosis of pulmonary hypertension or possible pulmonary hypertension, as Brian would point out, is probably an overestimate, but nonetheless 68%, even if it was only 40% of that, is still a significant potential amount with pulmonary hypertension. Post-TB airways disease, in a similar cohort, we're looking at using oscillometry and providing some intervention to these people with airways disease on oscillometry or spirometry if they have abnormal one or either of those, and giving them bronchodilators. This is just some initial results from about 30 of those patients, just demonstrating that oscillometry is I think a very useful test to pick up areas, airway abnormalities for increased resistance and reactance. So classification of treatable traits. I'll just touch on this very briefly because in the interest of time, but we'll go into this more in the afternoon. So the way that we're looking to classify treatable traits is into pulmonary, extrapulmonary and behavioural. Some examples of that. But the pulmonary traits should be those that relate to the lungs and respiratory system. They're a clinical characteristic and they're identified by different means. Extrapulmonary traits, some of which we've heard today about pulmonary rehabilitation, where pulmonary rehabilitation might be relevant. We've also heard about characteristics, behavioural patterns such as smoking, and we've also heard about anxiety and mood disorders, which is another important extrapulmonary trait to consider. Behavioural traits. So that's the last slide. Thank you. I'm pretty sure we're out of time for questions. Is that right?